Welcome to Shades of Migraine, a podcast series created by the Association of Migraine Disorders. Migraine isn't black and white. It's blurry and shadowy. But there are many forces at work trying to change how we think about and deal with this disease. We hope you'll enjoy listening to a wide variety of voices, including the perspectives of both people living with migraine and those that are trying to help. Each will share their unique shade of migraine. In this episode, Jim Carleton talks with Dr. William Young from the Jefferson University Headache Center about how the center is run and also gets his thoughts on migraine stigma and the best ways to refer to migraine disease and migraine patients. Dr. Young closes with some hope for the future of migraine treatment.
Well, we're pleased today to be talking with Dr. Bill Young of the Jefferson University Headache Center. Perhaps we're going to start with a little bit of introduction about what your work is like there at Jefferson, and from there we'll go on to some of the issues that are probably a little more passionate for you.
Sure. Well, I'm a professor of neurology. I started in the world of headache and private practice, and it made the unusual journey of going from private practice after 7 years into academic headache medicine. And I've been at Jefferson now for 20 years. I've become a professor of neurology, and I'm the vice director of the Jefferson Headache Center.
Oh, that's great. Needless to say, there aren't tons of these headache centers throughout the country. They're rather scarce, aren't they, for the most part?
Absolutely. There's a huge shortage of headache centers, of headache doctors, and even more so of academic headache centers.
Sure.
Let me tell you a little bit about how our academic headache center works. First of all, we have 6 attending physicians and 5 nurse practitioners. We have some nurses, some medical assistants who work with us. We are designed for the groups that are most severely affected. So most people who come to see us, see a psychologist, who's got expertise in pain medicine and, non-pharmacologic treatments. They see the nurse and their attending physician. When they come to see us, about a third are so badly affected that we want to bring them in the hospital. So a part of our program, which is obviously not for everyone, is actually hospitalizing somebody with severe, chronic, debilitating migraine, hopefully before they lose their job, but unfortunately sometimes, we only get a crack at them after they've lost their job, because, they deserve, one throw with intensive, excellent management to break a cycle of intractable, continuous daily headache. We have an infusion center for, patients who go into migraine status, where the migraine goes on for, 3, 4, 5 days, a week, 2 weeks, to break that. We think a lot about, their preventives, their abortives, how to and when to take, their medicine, and work for an individualized plan for a lot of our chronic migraine patients. We also see a lot of people who have cluster headache, and we try to address the particular needs of the cluster patients. It's very different from the migraine patients. The medicines are different, and they need different kind of services and non-medical treatments. The other thing is, we will not give up. So, you'll never hear at Jefferson Headache Center, I can't help you, I'm sorry, maybe you should find somebody else. We know that, there are people who, there may not be a medical answer right now. We'll keep working with them, and, we'll offer them the new treatments as they become available. We'll help them cope with what they have and make them better as soon as it's possible to get them better than where they are right now.
Have you had success with insurance managing to pick up a lot of these costs or
Oh, yeah.
substantially cut into them? Oh, that's great.
Yeah, insurance is paying anyway. If you have a diagnosis of chronic migraine on your chart, the chances are your insurance company is paying about $22,000 a year in medical costs from drugs and visits and tests and things. And if we can control the migraine and bring down those costs, in the long run, an expensive intervention like an intravenous treatment is well worthwhile.
Sure, could be a savings.
It could be a savings, yeah.
Absolutely.
If it actually works.
Yeah.
It is a savings.
One of our goals at the Association of Migraine Disorders is to help develop new fledgling, if you were, researchers to actually pursue migraine illness as a career track.
Yes.
To do that sort of research and to support these folks early on.
That's so important, and I thank you for that. It's it's very hard, and because there are so few of us, there aren't many models for the young neurologists, especially those being created in other universities where they don't have a headache expert, where they don't have a headache center. We need to find ways to bring them in to do the research and to train the doctors who are going to be experts at headache medicine.
In looking at your extensive body of work over the last 20 years, very clearly you are interested in the area of stigma and how that affects the treatment of migraine sufferers. And one vignette that pops into my mind initially is one that is on a YouTube video that you did about a school teacher. Do you mind sharing that with us?
Sure. I have this wonderful school teacher. You would be proud if she was your kid's history teacher. She's passionate about her students, and she's passionate about her subject, and she has terrible migraine. And, she describes going to work, and the question in her mind of whether she goes to work is whether she thinks she's going to be vomiting on the trip into work from her migraine. And her school, is saying, just get your family to drive you to go to work, and if you vomit, then you can still come on after that. I mean, it's really, people treat, the journey of somebody who has a severe migraine disorder so shabbily. It really is kind of offensive. As an aside, I remember when I broke my ACL playing soccer, and it was like I was a hero, and to everybody but my wife, who said, you're 55 years old and what are you doing playing soccer? But to everyone else, having migraine is the exact opposite. It's, people think, that it's their fault, and they treat them so terribly because they're stigmatizing this disease. And, I think it's time for people to get just a little bit mad about that and to think about ways that we could change that.
Sure. I mean, particularly negative about the school teacher story that I recall was the treatment that she received at the hands of her principal.
Exactly. It was her principal who, wanted her to come, go to class, vomit between classes, keep on working, and that's just not feasible, nor is it good for the ultimate control of her migraine disease. She does sometimes get good days, and she's going to stop having them, if we abuse her, and she abuses herself during these severe migraine attacks. It's terrible, and it's just indicative of how little understanding of this severe disease there is, by employers, family members, I hate to say it, doctors. It's time that people get educated and, learn to understand the difficulty and the dignity of the people who are coping with this bad disease as well as they possibly can.
the question might be why? Why, out of all the diseases, is migraine singled out for such treatment?
If I knew the answer, I'd be better at helping my patients, I think. But it's gotten seeped into the culture. There's a historian who's studying migraine, and she noticed that really in the Middle Ages and beyond, migraine was treated just like any other illness. So, you right next to tuberculosis, you could have migraine, then how you treat worms, then how you treat a broken bone. It was treated about equally. And then somewhere around the 1750s, something changed, and people started to ridicule people with migraine as trying to get out of their social responsibilities. They started to ridicule the doctors who take care of them as, being enablers of, these patients who weren't somehow worthy or didn't have a valid condition. And, in one form or another, this negative attitude towards people with migraine has stuck with the field, for the last 200 years.
Yeah. Given the high preponderance of women that suffer from this disease, is it possible that somehow this being tagged as a woman's disease has become as, second-class citizens, less than?
I think so. If men had as many migraine, there may have been a different history and a different level of understanding for this disease.
That's a great point. One of the pieces I've noticed that you've spoken on many times is the whole idea of what we call each other when we suffer from migraines, and how important language is as just a landscape of our culture, and how significant it can be just in terms of description.
This is the one thing that we can start to control, is how we speak about this disease. So let me put forth what I think is the way to go with the language that we use. First of all, it is not a migraine headache, it is a migraine. Headache is just a part of it. It doesn't encompass the nausea, the sickness, the sensitivities to sound. It doesn't, the fatigue, the dizziness, all these other symptoms that make it so much worse than just the pain. So, don't say migraine headache, say the headache of migraine. The other thing is, it's a chronic condition that's with you all the time. So say migraine, not migraines. Unless you're being specific, I had 2 migraines last month, you can say it, but my disorder, my disease is migraine. You don't say, I have asthmas. You say, I have asthma, and last week I had an asthma attack. So I think that that's a really important thing. I think that, migraine is many things. It's a condition, a disorder, and a disease. But for the majority of people who are patients, it's a disease. And I think it should be called a disease for those people who have something significant, something that can progress, something that disables. Call it a disease. It has all the features of what it needs to be a disease, and it's worth calling it that and pointing that out. There are a few other areas about how we can talk about migraine. I think, one of the issues is, what do you call the person with migraine? And people say migraineur, and I don't like that. I think if you're the person with migraine, you want to self-identify with the group, but otherwise, nobody should be painting you as being completely imbued in that disease. You're a person with migraine, an individual with migraine, a person who has migraine. It's not acceptable to say somebody's an epileptic or a depressive or a schizophrenic. That's just one of the many things that they are. They're a person with depression or a person with anxiety.
So you're leaving out the whole picture of the person when you just paint them as a migraineur. It's
Exactly.
Just, yeah.
Exactly.
Okay.
Those are some of the things with language that that we're advocating for.
Sometimes language change can take time.
Yeah.
Generations even.
Sure.
But
yeah. Or there's one more. Sufferer. So, suffering is something that only the person who has it can call themselves a sufferer.
Mm-hmm.
So I would never say you suffer from migraine. I'd say you have migraine. Mm-hmm. You are perfectly, you know what you're feeling, you know where your mind is at, your heart is at, and you can say, I'm suffering from migraine. But it's not my role to paint people with migraine as suffering.
Right. That's great. Given, just to change topic a little bit here, given some of the advances that are seem to be immediately on the horizon with CGRP antibodies and the like, could you speculate a little bit where we might see the field of migraine treatment a few years down the line?
First of all, I don't want to overpromise.
Mm-hmm.
I think that these are going to work very well for some portion of people that we cannot treat now. Mm-hmm. And I think that one thing we're quite sure about is people who are on it will have very few day-to-day side effects. Mm-hmm. So that will be a big advantage of these new medicines. So it's a very exciting time, but there's certainly going to be a large number of people who, unfortunately, we can't help them very much now, and this won't work for them. And then hopefully there'll be a decent size or large group that, of people we're not helping very well now who we can now, or we will be very shortly able to help really quite a bit with the new medicines.
Right. One of the items that people with migraine are waiting for is the pricing model. Yeah. What that is going to look like. In a meeting we were in previously today, it was brought up that the average SSDI recipient in this country gets $1,100 a month. Right. Compared to the price of some of these medications, as It's been speculated, it may be pretty much out of reach.
Right. Well, the question is, insurance companies and what are they going to pay and what is the copay going to be? But the migraine is the second most disabling disease in the world. And to think that there aren't some people whose impact from the second most disabling disease in the world doesn't justify a somewhat expensive medicine, that's wrong. That's just immoral. That you can spend $100,000 a year for somebody with multiple sclerosis who's not as badly impacted as many of my patients who have severe chronic migraine.
True. So would you say that there's a message of hope you might leave us with today relative to migraine treatment?
Yeah, absolutely. We think we're going to open up a new era with new medicines, and people who we haven't been able to help, we're going to help. And people who've been helped a little bit, we're going to be able to help a lot more. There are people for whom it's not going to work, but there are things coming after that. There's new options. I think we're going to get a long way in the next decade.
That's great. Anything else you might like to add before we wrap things up today? I like people with migraine. I think that they, that they develop a certain kind of toughness and they cope with the stigma and with, the societal culture against their disease in a lot of ways. But they, many of them are tough warriors and interesting people and have come up with creative solutions to their problem. I enjoy being around them, and I hope that
the new treatments, and efforts to reverse the stigma are going to make a big difference for them. And then, the last thing I would like to say is I hope that people, think about the stigma, recognize stigma, and think about effective ways to change the attitudes of the people who are, giving out these ugly sentiments. There's if you come up with a really good zinger, you might feel really good about it for, a minute, but maybe that's not the best way to educate someone and bring them along to having understanding and compassion about this disease.
Sure.
We need to find ways to talk to people who are less understanding and aware and bring them, some part of the way towards, viewing persons with migraine and other headache disorders more fairly.
Right. Thank you so much today.
Thank you.
And thank you for tuning in to Shades of Migraine. For more information about migraine disease, please visit migrainedisorders.org.